Good morning, everyone. It is Tuesday, November 30th. Welcome to the Morning Medical Update. Thank you for joining us here on Facebook and YouTube. This year marks 40 years since the start of the HIV/AIDS epidemic. While there is currently no cure, COVID-19 is helping with research. We're going to take a look at the treatments currently available, why some HIV patients fear getting the COVID vaccine, as tomorrow marks World AIDS Day. Today, we are joined by Dr. Lisa Clough, Dr. Matt Shoemaker, and Dr. Dana Hawkinson, all infectious disease experts here at the health system. Of course, along with Dr. Steve Stites, our Chief Medical Officer. So it doesn't get any better than this group of people when it comes to talking about viruses and pandemics, especially as we are learning more and more about this new Omicron variant. So make sure to get in your questions. You can send us to us on YouTube, Facebook, Twitter, and you can email those to the Medical News Network. You can find those links right there on your screen. But first, let's get over to Dr. Dana Hawkinson joining us with our numbers today. Good morning to you.
Yeah, well, I was told today it's probably a not so special day. We actually have 27 active patients in our hospital. We have 7 of those in the ICU and 4 on the ventilator. Still 14 recovering in that recovery period, so a total of 41. And Hayes also has continued to have high capacity with 15 active infections and 12 in that recovery period as well.
And Hawkeye, the answer to the riddle is 40 days and 40 nights. What's the question?
I said Lent, but it wasn't.
It's how long it's been since we've been at that high of a number. It was back to October 20th, so not the kind of numbers we want to be with, but we shouldn't be surprised by that. We've watched the virus march across western Kansas on the heat maps. We know it's been heading this direction. I think we're all concerned, and we know, unfortunately, we follow the MARC dashboards that kind of show us what the local hospitalization and counts are doing. You can follow it at kansas.com as well. But the challenge has been that the lack of reporting over the holidays makes it especially difficult to know what the numbers are. But hospitalization, those are a real number. So that jump to 27, I think, heralds perhaps yet another wave that we have to be thinking about.
Yeah, absolutely. Looking at the case counts in the United States today in New York Times, you see a distinct drop on the 24th of November.
Yeah.
So, I think that was all a function of the holiday weekend.
It's not
and I think more importantly, as we have said now for quite some time, the best bellwether is really going to be the hospitalizations.
Yep, and the hospitalizations are rising, and that's not to be unanticipated. So I think we're concerned about that. Jess, let's go ahead and check. Are there reporter questions? And then after that, we may want to talk just for a second about some updating news around Omicron.
All right, let's do it. Any reporters on the line?
Yes, good morning. This is John Pepitone over at Channel 4.
Good morning.
Hi.
How are you? Thanks for taking my question. I appreciate it. I wanted to ask about national reports out this morning concerning preliminary tests of antibody drug treatments from both Regeneron and Eli Lilly, which say they're not as effective against the Omicron variant. And I wanted to ask the doctors, do you think will this limit treatment options available for patients before they enter the hospital should this variant become widespread here?
The good news, John, is we have like the master panel here. This is like the best possible day to have all these people here. In fact, because we have 3 infectious disease experts here, we've quarantined the place because, we had to quarantine the studio since all these guys are here. I think the one thing we have to remember is that we're going to see a lot of bits and pieces of information about the Omicron virus. We got to be careful we don't think of it as, oh my gosh, virus, and not get into too much of a frenzy, because while we are all concerned about the number of mutations on this virus, some of this data is pretty preliminary. So Hawk, I'll turn first to you. Thoughts about the Regen cocktail and whether or not it may be a little less effective against Omicron?
Yeah, and we'll pull up some slides here in just a minute. But, to answer that question, we know that the antibodies probably wouldn't last a long time. We don't have full data yet. We know that Regeneron said they suspect that their antibody cocktail will not be as effective. And Eli Lilly, and if you remember early on when when Alpha was circulating, Eli Lilly actually was pulled, and their authorization was pulled because it didn't work. However, when Delta came back, they found that you actually have activity with those monoclonal antibodies. So this could be a shifting thing as well. I think we still need to wait for the full information about how effective the monoclonal antibody cocktails are to this variant. and that data should be coming out fairly soon. It's probably easy for Regeneron and Eli Lilly to do those and really get exactly how much of a reduction in activity and protection those monoclonal antibodies offer. And if you were talking about mutations, going through all the mutations, the biggest thing that they've seen is that there are about 30 or more mutations in the spike protein itself. And we do have some slides I have taken from covariance.org. And if you see right in the middle there, in that middle column, I know it's probably difficult to see, but all of those rows there in that middle column, that is the Omicron variant. And this is compared with every other common variant that we've seen, alpha, delta, beta, gamma. And you can see, especially up at the top, that there are similar mutations. Those are all signifying that those are similar to each other. The biggest ones that we have seen, and these are again amino acid substitutions within the spike. So things like the deletions at 6970, 484, 501. All these different amino acid substitutions have seemed to confer more immune evasion or antibody evasion. But we still have some hopefully there are some conserved regions. And then if you go down here, this is the second part of that graph that we can see, or that list. This is taken from covariance.org. As you can see, in that middle column tends to be all of those other spike mutations that we see in Omicron. So there still are other mutations that are not in spike that are important, that could aid to immune evasion, such as antagonizing our initial antiviral response, just a lot of different things. So again, we have a lot of mutations, a lot of amino acid substitutions. We really got to see and find out how biologically relevant are all of these mutations, and that will take some time. Hopefully we will get some more information fairly soon from Eli Lilly and Regeneron about their monoclonal antibodies.
We know they're testing it right away,
Absolutely.
early on, and I think we always have to be a little careful about some of this really early information that comes spilling out. So, Dr. Shoemaker, this morning it's being reported that in South Africa, children are starting to be hospitalized a little bit more in some provinces, or maybe it's more mild than the Delta variant. Any thoughts about how we should interpret this very early information?
I think it's probably too early to tell at this point. I think we'll have to kind of see how these patterns play out. We are worried about increased transmissibility, but we don't know about severity of illness, just like we don't know about effectiveness of vaccine and the monoclonal antibodies. So at this point, unfortunately, it's watchful waiting.
It is, I think. And the other thing I was noticing is that Pfizer and Merck seem to be indicating that their new pills they thought would still be effective against it, so that might be good. Of course, we don't know how effective those pills are until we see that final data at all. So, John, did we answer your question? Anything else you wanted to ask?
Yeah, you were leading into it asking about the antiviral drugs, because I've read these national reports saying that there are other options that attack elements of the virus that seem to be unchanged in Omicron. I guess GlaxoSmithKline has got an antibody treatment that has been approved for emergency use that they think could be effective. And then you mentioned the Merck and Pfizer pills. What's the timetable for them, if you know, if they are unaffected by this variant?
Dr. Clough, thoughts about those? Let's start with the Merck and Pfizer pills, and any thoughts you have around that.
I think it's encouraging that we have some alternative therapies and that we have some reduction in the severity of illness with these therapies. And I, as far as the timeline, I don't know that we have a good sense of that right now. I know that there are people that are working, the studies are being done, and we're hopeful that those will remain effective and be available to the general population in a
fairly soon. And I think Merck's goes before the FDA panel. If I remember, it's today or tomorrow, I think. So it's coming up. And this is where we have to be careful, because in their initial data, Merck reported, 50% reduction. And then they said, well, at the close of the study, it's actually a 30% reduction. So that's why it's so important to get all the information in, look at it carefully, and then react to it. And I think what we have to be thoughtful about is around the Omicron virus or variant is that it is still so darn early. Hawk, there was some speculation that I looked at this morning that said, maybe Omicron actually arose arose in animals and got transferred to humans, didn't come from HIV populations, because some people are saying it's so weird, it's such a new variant, it's so wild. it all just feels like it's just so new.
Yeah, absolutely. And again, I think what we are continuing to see is just a natural evolution of this virus for one reason or another. Certainly, we believe, and the best evidence points to a spillover event from another animal to the human species. We know that other animals can be infected. We know that through replication and even sometimes recombinant events, this virus can change as it had. There can be certainly spill back over once one of the animals is infected. We don't really know exactly where or how, but we know that through the more viral replication, we know that certainly more mutations and changes can arise.
Other questions?
Good morning, guys. This is Charlie from KSHB 41. Appreciate your time.
Hey, Charlie.
We have a question from a viewer who called into our newsroom today that I wanted to pass on to you. She was concerned that maybe some booster vaccines are stronger than others, and if she got J&J to start off with, but then a different booster, is she at a different level of vaccination than others? Does she need to be concerned about exactly which boosters she's getting?
All right, how do we do this, Nate? I mean, or Dr. Shoemaker, there's a lot of questions about mixing and matching, and if you've had J&J, should we follow it up with a different one?
At this point, it looks like most of those folks who get the booster should probably get one of the mRNA vaccines. So if they got a J&J to start with, then get either a Pfizer or Moderna. And if they had a Pfizer or Moderna, then get a Pfizer or Moderna. But we think the mRNA vaccines are interchangeable. But that seems to be the best evidence.
So J&J followed up with one of the two mRNA vaccines. Dr. Clough, do you think that there's any validity? I mean, there have been some thoughts that the Moderna has better outcomes at 6 months as far as antibody levels than Pfizer. Is that just something we should really think about, or is it a variation of the amount of drug, the time between the initial shot and the booster? What do you think?
Yeah, I think that they are interchangeable, and that we should feel confident about the response that we're getting with both Pfizer and Moderna, and I think that we should move in that direction.
And Hawkeye, we've also talked in this program so much that there's antibody levels and there's a whole lot of things that happen in your immune system beyond that.
Yeah, I would agree with all these points. I think a lot of experts and practitioners are recommending an mRNA platform after a single dose of that Johnson & Johnson 4-year boost. But we know that all of the vaccines continue, even 6 or 8 months out, continue to provide great protection against going to the hospital, going to the ICU, and death. One of the other reasons for getting a booster now or getting additional dosing is because we do believe that when you do have that boosted immune system from that dose, you will help reduce transmission, and we know that there is good evidence that transmission is reduced in those vaccinated households when as many people as possible in those households can be vaccinated. So there is some transmissibility and transmission data there as well, showing an effectiveness, especially in the first few months after the third dose. So it is important to get boosting as well.
Other questions? Jess.
Okay, so Dr. Stites, I just want to kind of kick off our conversation, but as we know, COVID is dominating the headlines, especially with this new Omicron variant possibly making its way to the U.S. this week. So while this virus has been horrendous, as we know and as we hear, it is helping battle another virus with no cure, that is HIV. There are approximately 4,000 people living with HIV/AIDS in Kansas City, and an estimated 150 new HIV cases reported annually. And that is according to the Missouri Department of Health and Senior Services. So I want you to dive in and get to our panel. For that, Dr. Stites, I'm going to hand it back over to you for a great conversation.
Awesome, thank you. All right, so Dr. Clough, Dr. Shoemaker, Dr. Hawkinson, what impact is COVID having on HIV patients in our area? We know that they're obviously immunocompromised. Okay.
Well, one of the things that I think we've all seen is, at least early on, concern about being out in public and accessing care. So we had patients skipping appointments because they were worried about being exposed to COVID. We were able to overcome that through telemedicine, which helps with the visits, but still we need labs to monitor how they're doing.
And I think that's still going on. There are a number of individuals that are just reluctant to remain engaged in their health care because of that. So trying to meet them is important step
And how are HIV patients doing, Hawk, once they get COVID-19? Because I'm sure there are some COVID-19 or some HIV patients who have contracted that disease.
Yeah, I mean, I would just like to echo what my colleagues had said first, because we have patients who are in the service community, whether it's waiting tables or working at libraries or other service, and so it's really important that the other people in that community really understand that what they do can affect somebody else, and so I think that's important. I've had that voiced to me several times by my patients who are interacting, doing those things that we need to be help done every day. And again, it's working at stores in the service industry where they come into contact with the public, where they are certainly at risk of getting the infection. So it's important to understand those actions that you do affect others.
Yeah,
and certainly I think most of my practice, and I think are very well controlled. I'm lucky I don't have anybody that is really too difficult to control as far as HIV. And when we talk about well-controlled HIV, that means that their viral counts are undetectable and their CD4 count is high. So I've had pretty good success, but we know that there are risks for those HIV patients, especially those unwell or not well controlled patients with very low CD4 counts, with high viral loads, who just can't get a handle on the virus. And I think Dr. Shoemaker or Dr. Clough would have more insight to that.
Yeah, I mean, we know outcomes for people living with HIV who have low CD4 counts or who are not on antiretroviral therapy. They do worse. Increased hospitalization rates, increased rates of mechanical ventilation, increased risk of death. It's been proven in multiple studies. KU participated in a multi-center cohort study looking at 286 patients, and we found similar trends.
So it shouldn't be surprising, because the rule has been all along with COVID-19, the more immunocompromised you are, the more at risk you are, whether it's HIV, organ transplant, cancer, chemotherapy, etc.
That's right.
The list goes on and on.
Right. And helping those individuals to engage in care and to control their HIV, to stay on medications, initiate medications, and to take care of themselves is an important step in helping them to stay healthy during this pandemic.
And have we seen a rise in mental health issues in HIV-positive patients who feel more isolated from this pandemic?
Certainly, I think that echoes the general population. There's just been a lot of opportunity for people to spend time alone, alienated, to be separated from their community, and I think people living with HIV are no exception to that. And in addition to that, they have the increased burden of their disease and trying to deal with that. So yes, reaching out and trying to provide services and to encourage people to stay connected both with their medical community as well as their social community is such an important step.
So if I put on the retrospectoscope for just a moment and look back 40 years ago, would have been kind of at the beginning of the HIV epidemic, and I think I'm the oldest guy in the room, unfortunately, yet again. And so
who's counting?
Who's counting? So I remember as a fourth-year medical student doing a neurology rotation. And it would have been in 1985, and there was a patient no one could explain who was gay. He'd had this funny spinal cord. Nobody could understand why he couldn't move his arms and legs. We'd seen patients with these coughs and these lung infiltrations we really couldn't explain. And then all of a sudden, the story of HIV really broke. And gosh, yet another world we forget. That was a terrible pandemic, not as transmissible, but much more deadly than Delta, and we forget about that.
Yeah, I mean, in 1985, the average life expectancy for a person living with HIV was 2 years. Now in 2021, people living with HIV, if they take their meds and their virus is undetectable, they're going to be like everybody else in the Midwest. They're going to live to be elderly, and they're going to die of a heart attack, just like all of us in here, right?
Be careful with that. I don't want to yet.
But, the other thing is trying to identify those people who are not in care or that don't know they're positive. 13% of people don't know they have HIV that are living with it. So we have to do a better job as a health community getting out there, testing, and identifying these people so we can get them on meds and get them undetectable so they can live a long, healthy life.
Well, I've said in this program before, as a resident, then back in the late 80s and a fellow in the early 90s here at KU, especially in the late 80s, the mortality rate once admitted to the hospital was 80%. It wasn't 8% or 10%. It was 80%. And we would have whole floors of HIV patients, all of whom were dying. So to me, that is in some ways the worst pandemic I've experienced. Delta is also terrible, don't misunderstand me, because it's so much more transmissible, so many people die. But to watch 80% of your young population die in the hospital was, I think, took a tragic toll on all the healthcare personnel then.
There's no doubt, because most of those folks at the time were young.
Yes.
But to look at the 40 years of the HIV pandemic, we've had about 700,000 deaths over that 40 years.
And
now over the 2 years of the COVID-19 pandemic, we've had pushing 780,000.
Yeah. Isn't that striking?
Yeah.
Yeah.
And what also I think, Dr. Clough, we is you look back at it, this thing about first we had to have faith in each other, then we had to have hope with the AIDS epidemic, and then science.
Yeah.
And where we are today is so different than where we were yesterday.
Yeah, exactly. I mean, there still is so much hope to be had, and that's the first thing. Science is important. It drives our knowledge. It drives what we believe are the next best steps for people, and it helps us to progress and to have arrived at this place with our HIV care that we can help people living with HIV to live long and healthy lives. But we need to stay engaged in that process, and we need to continue to reach out to those individuals who have yet to be identified or are at risk for acquiring infection, and really that's where the hope lies, I think.
I even remember back in the 80s, we heard so many of the similar refrains. It's a disease of gay people. It's a disease of drug abusers. And suddenly it became a disease of hemophiliacs because of blood transfusions. Then it became a disease of pregnant moms who bled at delivery. Then it became a disease of people who had heart attacks and had to have a transfusion during open heart surgery or a GI bleed. And suddenly it became a disease of all of us. And then some of the political divisions died down. We can only hope that some of the political divisions we experience today around the Delta variant, both here in the United States and across the world, which clearly make fighting this pandemic that much harder, just as it did with HIV, for those of us who were there then, that much harder, die down so we can try to attack this together. Thoughts about that?
Yeah, I mean, I think, back when people didn't even want to go on the same hospital floor as AIDS patients, and it was nowhere near, as this was brought up, nowhere as near transmissible. I think we do need to get away from the political divisions and focus on this disease so that we can keep everybody healthy, because we know that healthy communities and healthy countries have much more production, much more quality of life. The economy is stronger. Everything is better when you have a healthy population.
Yeah. So a human rights campaign in California found 32% of LGBTQ adults say they are worried that getting vaccinated against COVID-19 could negatively affect their medication for treating or preventing HIV. Dr. Clough, that's
Well,
true?
I think that's a reality of where we find ourselves, is that people are uncertain about what information to trust, and that they are driven by discrepant sort of opinions. But vaccination is safe in HIV-infected individuals, and it's important that they seek that care. And COVID doesn't influence their medications or how they are taking care of themselves. And so we need to engage in our care for COVID amongst our HIV patients, just as we would for any other individuals that we're working with.
So COVID vaccine with HIV doesn't make you less safe because it affects your medications or something. It actually makes you more safe because it protects you against
Right,
COVID-19.
and that's another good point. It does, and it's an important part of the armamentarium that we're utilizing in order to stay healthy during this period of time.
So as we approach World AIDS Day, Dr. Shoemaker, there have been some comments out there that saying, hey, some of this stuff we're learning from the pandemic is actually going to help our treatment of HIV. Talk to us a little bit about that.
I think a couple of things. One is it'll help us to better engage racial and ethnic minorities, particularly for us in the LGBTQ plus community, and figure out better ways to address vaccine hesitancy, whether it's in our HIV positive patients or our HIV negative patients, because vaccine preventable diseases are things that we have been on the forefront for our entire careers, whether it's COVID or influenza. So we want to continue to try to educate those people, give them the best scientific evidence we can, and dispel any misinformation that they see on Facebook or any other social media, except for this podcast.
Absolutely. We only tell the truth.
Yes.
We won't flapjack.
That's right.
All right. So, Hawkeye, what is the one thing that you'd want everyone to know about HIV and its prevention?
There are so many things, but HIV is a preventable disease. We have good drugs now to treat it, but the best treatment is prevention. Be smart, use protection. I think you have to, if you start to engage in those risky behaviors, you really need to have a talk with your partner about those things so that everybody can be on the same page. But the best thing to know and understand is it is a difficult disease to get when protection is used. And so using protection, having those thoughtful conversations with your partner is most important for prevention.
So
I was going to just
Please.
add, and in addition to prevention, including the idea of PrEP, that there's medications that can be taken on a regular basis to prevent infection, and that's such an important component. If we had that
so
with
you take the medications if you think their behavior may be risky to help prevent transmission?
I'd like to say if you're engaged in behavior, doesn't have to be thought of as risky, but behavior that you should be conscious of what the opportunities are for you to prevent sexually transmitted diseases. And for HIV, part of that is including the medication that we refer to as PrEP, or pre-exposure prophylaxis, that can be taken on a regular basis for the most part. So.
Yeah, we have an active program doing that. I have several people I know, my colleagues as well, and it's it's safe and effective. It's managed by a physician, so just as Dr. Clough said, it works.
I mean, the other thing to add to PrEP is that we know now that people living with HIV, if they're undetectable with their virus and they're undetectable for at least 6 months continuously, they cannot transmit the virus to their partners.
Which is great news.
Which is great. So then it goes back to that 13% that don't know they have the virus, who have detectable virus in their blood, that we need to identify and get on meds so that we can break that cycle of transmission.
So regular testing for HIV is important to understand as well.
I think it's become so, HIV feels like it's such a curable disease now that we forget that it's still a prevalent disease. Where can people get therapy here in Kansas City? Are there local HIV clinics? How does that look?
Right here at KU, we have multiple providers. We specialize in HIV care. We're on the front line of the studies. Just this year, a long-acting injectable medicine that you get once a month was approved. Dr. Clough was the person that spearheaded that part of the research here at KU. So they can come right here.
Tell me a little. Okay, you start.
I
heard you take a breath.
In combination with that, we have a large team of dedicated nurses, pharmacists, case managers, social workers to help with all of that too.
So we've got a vaccine already for COVID. Why has it been so hard to get vaccines for HIV? And second part of that question, does the development of the mRNA platform for COVID give us hope for HIV? Dr. Shoemaker?
Well, I'll start with the second one first because that's an easier question.
We'll give Hawkeye the other one, right?
Yes, that's right.
I love to do that too.
I think the
I don't know
mRNA
that answer.
vaccine
Hawkeye.
platform opened up an intriguing area of research for a potential HIV vaccine. The struggles over the years, and they've tried, and there have been some early successes where they thought, hey, this is the one. There was a study out of, I think, Southeast Asia and Indonesia where they thought, okay, we finally found an HIV vaccine, and then we found that it didn't work. So it's trying to figure out which proteins are going to be able to elicit that immune response to a high enough level that the virus can be conquered and not enter your cells.
Got it. So why is it so hard, Hawk? I know I've asked you this question before.
I'll try to answer and then shoot it over to Dr. Clough. I think there's multifactorial reason here. First of all, the nature of the virus itself. It does mutate. It is difficult. We think coronavirus mutates quite a bit or changes. HIV does even more so. The other issue is, as Dr. Shoemaker talked about, once the virus gets into your cells, it actually incorporates itself into the DNA. And so there can be cells that are tucked away somewhere that aren't even seen that could have HIV in them in the DNA. We know coronavirus does not do that. We know the mRNA vaccines do not do that. And so it's very difficult to fully eliminate HIV from the body, even when you have done all of those things and taken the medicines, because we know when it's incorporated into the nucleus, into the DNA, it can be there forever. And so it's very difficult to treat from that way. But just blocking the virus from getting into the cells is a very difficult thing, because we know about antibodies. We know that, early on after vaccination or infection, you have very high antibody levels that are circulating that do a very good job of cleaning up any free-floating virus. But after that, we know that there's a contraction of those antibodies, and so you don't have as many. And so you do have that chance, that very off chance, that one viral particle or two viral particles can get into a cell, and once that starts, you start that viral replication cycle, and then that's what infection is. And so it's very difficult. You really need to protect that virus from getting into all of your cells, because once it gets into a cell, it can start replicating, it can incorporate into the DNA, and then you have full-on infection. So, and I don't know if you have anything to add to that.
No, I think it's a tricky virus.
It's very
It is a
tricky.
tricky virus. And yes, I love Depanoc. These hard questions come in I don't know the answer to. That's when I act like I'm really smart. I said Depanoc. All right, so Jess, I bet there are some questions coming from the community. We probably need to take those on.
Yes, let's get to them. We've got a lot of good ones. Let's see. Okay, so Melissa wants to know, have the doctors heard of any new information of any organized efforts to get more vaccine to underfunded countries?
Ooh, great question. And just to say, that comes back to our concept that we're all in it together, right, Dr. Clough?
That's right. We are all in it together, as Dr. Hawkinson was even mentioning back to, his experience of his patients working in the community and being exposed. That's what we're all about. We should be helping each other and looking towards each other.
So I know that China today announced 1 billion doses of vaccine for Africa. I think that the Biden administration said they're going to send, I think it was 1 million doses to Africa. So, here's the reality. We talk a lot about getting Americans vaccinated and how important it is. And it is important as a bulkhead against the disease. But at the end of the day, this isn't an American problem. This isn't an English problem. It's not a South African problem. It's a world problem. And we like to draw political lines around it. And sometimes you can do that around politics. But the problem is that viruses don't really care about your politics. They don't care at all. They don't care what country you're from. They don't care what color skin you have. They don't care what your sexual preference is. Viruses are looking for a host, and all humans can be the host. So the only way we finally get full protection from COVID-19 is when we protect all of humanity. And that is a bigger job and a bigger task than what we've really spoken to so far and what we as a world have owned up to. So the more we own up to it, the sooner we can solve this crisis.
And, equality and the concept of inequality is a driving theme between both COVID and HIV. And in fact, that's one of the themes for World AIDS Day tomorrow, is addressing the inequalities in HIV. And we need to do the same.
And those of you who have also lived through this crisis will remember the story about "And the Band Played On."
That's right.
And to some degrees, that feels like that refrain is true again with HIV or with COVID-19, right? And it's like the story of the Titanic. Things are going down, but the band keep playing. It's like nothing was going on. And that's was clearly what was going on, is people tried to ignore the stories around HIV because it wasn't going to be their problem, and the band played on. And then the COVID-19 pandemic, we've tended to ignore poorer countries and hoarding vaccine as if the band played on, failing to recognize once again that this is a disease of all humanity, not just special segments of it.
That's right.
Yeah, and I think that creates a situation where we can potentially see more variants. If we cannot get enough people vaccinated to reach that herd immunity level worldwide, we will continue to see the emergence of these variants.
In my happiest moments, I think about how something like this should rally mankind to come together, as opposed to allowing it to split us apart.
That's right.
Because if we rally together, we can solve it. And then what else can we do together? But so far, we've still been kind of stuck into our own little segments and arguing about some of the most simple facts of science. Right. And if you can't get past that, it's going to be hard to solve it as a world. Jess.
Taylor wants to know, question in regards to viruses. Given a virus wants to survive and spread, wouldn't mutations that are less deadly and more transmissible be best for the virus to continue to survive and replicate?
Dr. Shoemaker, I saw you nodding your head.
That point is exactly right. It's not in the virus's best interest to kill the host, but viruses aren't sentient beings. They're not smart. They're just, some of these mutations are random, and as Dr. Hawkinson said earlier, it's possible that, for instance, the Omicron could have jumped from an animal source to us, and maybe the mutations that are detrimental to the human were not detrimental to the previous host. So it'll take a while for the virus to continue to mutate to find that state where it can continue to survive in the new host.
And the problem is you can kill a lot of people trying to figure that out.
That's absolutely
This,
right.
there's no data safety monitoring board for viral illnesses. There's no internal review board or ethics commission looking at it for the viruses. So they're going to do what they're going to do, and they may kill the host, but what they're really trying to do is infect cells and reproduce. Hawkeye, it could be a long time before viruses get that smart.
Yeah, I love when we anthropomorphize the viruses. Remember, they're non-sentient beings, but all it does is get into a cell and reproduce. That's what it does. But it is that delicate balance there of keeping your host alive so you can transmit and spread easier. And then obviously what happens on the other side of that is death. And it is a delicate balance. A lot of viruses do that fairly well. Those common cold viruses, SARS-CoV-2. HIV is able to keep its host stays alive, for decades. But when it's uncontrolled, it can spread to other people, just as Dr. Shoemaker talked about. So it is that delicate balance there. Nature just seems to work that out right now. SARS-CoV-2, one of those benefits that it has is that it is able to spread prior to anybody getting any symptoms at all. And so the mortality rates are low, and so it's just an interplay of all those things. It's not one simple black and white thing, but it is shades of gray and just grades or graduations of different aspects of the virus and the infection.
So, okay, here's my question to you guys. And this is a philosophical question, so we're going to have to ask our ID doctors, including the guy with the bow tie, this question. So,
luckily, I majored in philosophy as an undergrad.
That is outstanding, because here's coming to you first. So then why do viruses exist? If there's such a problem for humanity in the world, why are they even out there? What is the good that allowed viruses to evolve and stay active?
I'm not sure I have the answer to that question.
That wasn't in your philosophy course.
Yeah, we didn't talk about that. Although I did get my undergraduate degree from MU, so you might poke fun at that.
Well, no, my med school
why.
degree's from MIZ.
Rock chalk.
ZOU.
There you go. Rock
Well, we should ask Dr. Stites, why do you think that?
Okay, well, here's my thought. I think it's part of evolution, right? Because viruses also introduce mutations into human hosts, which can then lead to survival advantages, and so they are a mechanism of selection, and so you alter our DNA just as you've altered through the messenger RNA in the viruses. So I think that's probably there's something around that.
Yeah.
I'm not smart enough.
They're just part of the complex process in which we live and to which we are so unaware of as to the degree to complexity.
Right, because we could ask the same question about rattlesnakes and ticks or mosquitoes.
You could.
All things I don't
We're
like.
part of the community.
True. Well, I would say snakes are around to eat the rats.
She went up to you, Mr. Philosophy.
I know. She did. She stole my thunder.
Jess.
All right, so Isaac I thought you'd appreciate this. He says that Omicron sounds like the name of a villain in some action movie. And I have
Yes,
to
it
kind
could
of-
have been. It could have.
Yeah.
I think there may have been the Omicron maneuver in Star Trek. Actually, that's not true as a Corporate Right maneuver, but that's a different question.
That is a different question, but I kind of agree with them. So, so if this supervillain Omicron arose in an HIV patient, does that mean that HIV antivirals could cut down on the formation of new COVID variants, at least indirectly?
Interesting question. Okay, Hawk.
I'm going to say no.
No.
And we'll defer to my colleagues to answer this as well. But there's no evidence at all that the antivirals we use for HIV have any activity to SARS-CoV-2.
But molnupiravir doesn't it have an HIV drug in it?
Yeah, it will contain in the combination therapy ritonavir, which we use as more of a booster, and this is to boost the levels of the other active drugs. It's not to actively treat HIV. It won't be used to actively treat SARS-CoV-2 either. Basically, it is used to help stop the degradation of that drug that you are using, so that it stays high levels in your system, so that it can actually affect the virus itself.
Dr. Shoemaker, you were.
Well, what these are, they're what we call protease inhibitors. So they attack a particular protein in the cell that helps the virus reproduce. And yes, we use them in HIV, but we also use them in hepatitis C. So all of these cells, all of our cells have proteases. I mean, that's how we elongate our DNA and our genetic material and cleave it.
Okay. Jess. Yep, you're on Zoom. You're on mute.
Guys, can you unmute me?
You're unmuted now.
Okay. Okay, so Andy wants to know, I've heard that eventually we will all have to be infected with COVID because it just won't die out. That we're just prolonging the inevitable by masking and staying apart. Your thoughts?
Oh, boy. Dr. Shoemaker.
So,
No.
that is incorrect. The best way to get the immunity is through vaccination, right? And if we continue to allow this to spread and perpetuate, then we run the risk of continued mutations.
That's right.
And the continued mutations, then eventually there could be an escape variant where the vaccines, the monoclonal antibodies, the antivirals we've developed will not work. So our best bet is to get people vaccinated to terminate the spread within the community and reduce the likelihood of continued variants.
Dr. Clough.
I would agree. I think vaccination is certainly our key of controlling this pandemic.
Dr. Hawkeye.
Yeah, I'm going to take it just a different spin on that. I think the question I thought was we will all have to be infected. I think eventually we all will be infected in one form or another. But the problem is we can't allow infection and the virus to go out unmitigated because we know what happens when that does happen. We have seen what happens in the pre-vaccine era with the hospital capacity and the amount of morbidity and mortality, death that occurs from this virus. So the best way to then prevent, we aren't worried about the cases. We aren't worried about necessarily the cases. The vaccines were never created to stop cases or an infection. What we have concerns about is the hospitalizations, the severe disease and death. And we know that the vaccinations prevent that very, very well. And so if you are talking about just any infection, say if you're in a high-risk situation indoors at a gathering and you get infected, but you have mild symptoms or no symptoms because you've been vaccinated, that's great. That's what we want. What we don't want is the continued rush and the capacity issues of people coming to the hospital, people losing loved ones, friends, because of this infection that is so easily preventable as far as hospitalization and death goes with the vaccines. And so, eventually, as our children and the generations come up, who knows what will happen, if it will become more like the common and cough, cold coronaviruses that we know about that have been around for hundreds of years, or some of the other common cough and cold viruses as well. But that is an adaptation that we as a species will have to undertake, and that typically takes decades or longer than that. But vaccination is what is going to help us from keeping people out of the hospital, keeping loved ones alive, friends alive, keeping people healthy so that they can continue to have a good quality of life and continue to work. And so I think that is the main point of the overall pandemic, because this virus now really is endemic and probably will be here for some time. So we do have to learn how to live with it. And the best way to learn how to live with it is to help prevent those most severe cases of disease so that people aren't going to the hospital, they aren't going to the ICU, and they aren't dying.
And I think the HIV, story should be informative to all of us, right? We still have HIV, but it's now a treatable, survivable, normal life expectancy disease. And how did that happen? It happened because of science. And what I think alarms all of us is that the refusal to accept science in favor of internet rumors and fear-mongering. And that gets on our way of solving COVID, just as it got in our way of solving HIV.
Dr. Stites, we have time for a couple more questions.
Please.
Okay, so Mary wants to know, Dr. Hawkinson refers to conserved areas. What does he mean by that?
Yeah, so just a quick little bit of some definition. So conserved means basically it's not really changing, or it doesn't change that much. We know that there are variable regions, meaning that they change, or hypervariable, and those are the areas on the receptor binding domain, or the RBD, of the spike protein that allows it to bind to the receptor on our body. Those change quite a bit, and that's why sometimes those monoclonal antibody cocktails, like the Eli Lilly, did not work with the alpha variant. But the conserved regions are the regions that help not only antibodies, but help our T cells to recognize the spike protein so that our T cells can mount an adequate response. So conserved basically just means that it really isn't changing much. It isn't mutating much. The other things we are always talking about is how is the virus able to outcompete? So far, nothing has shown to outcompete Delta variant. Delta variant gets into a geographic region, and we saw how quickly it spreads and becomes the most dominant one. Why is that? Because of viral fitness. Fitness just means that the virus is able to replicate better or more quickly, and able then to outcompete other variants within that geographic region and become more dominant. So those are just a few of the terms. Basically, conserve means it really doesn't change much. And when we're talking about Omicron or Delta, we really want to understand what is the fitness and how is it more fit that allows it to outcompete some of the other variants or other viruses within that geographic region as well. So hopefully that helps.
And I think most of the people that we're reading today are saying that vaccines, because so many, if you think about it, there are 30,000 sets of instructions to build SARS-CoV-2.
Yeah.
And you've now mutated 30 of them in the spike protein and maybe 40 or 50 overall.
Yeah.
But that meant that the other, 29,950 sets of instructions are all the same, which is why we have so much hope that vaccination still will be effective.
Yeah.
I think early prognostication has been that, it may not be as effective, but it's probably going to still work pretty well.
Yeah.
So the answer to all this is to make sure you've been vaccinated.
And that's the key to the vaccine, because we know that the mRNA and the adenovirus vector vaccines are all that original Wuhan strain spike protein. And why is it so helpful? Why do they continue to have such great activity and create a great immune response? Number one, it's because of those conserved regions that really haven't changed much at all or changed very little. But it's also the fact that we know that when you get boosted with additional doses of vaccine, that helps broaden your antibody response and causes that further evolution of your immune response to SARS-CoV-2 as well.
Betsy wants to know about an article that she read in the Washington Post from a doctor who is a great proponent of the vaccination, but questions broad boosters for all adults. Your thoughts on that?
Yeah, so I've read that article, and one of the things that said is, gosh, do we need booster shots, or are we better off trying to make sure we get original vaccination across the entire world? I think it's one of the points of that discussion. I think that's a great discussion to have. I think the answer is actually it's C, all the above. Everybody should get their first series of shots. We need to get them across the entire world, and we need to get everybody across the entire world boosted to help protect against more of the rise of more variants that we can't control. And I think that's really ultimately the answer. And it's sort of it's a philosophical question about which way to go.
Well, I agree with you. I think it's all of the above. But to say we need to vaccinate everybody in the world is easy to say, but it's hard. There's a lot of logistics
really
in doing that.
Yes.
Right. But I think it's an effort worth undertaking and continuing to do for all the reasons we've already said.
Yeah.
Jess, we should probably get around for final questions. Final
Okay,
thoughts.
I am. I just have one comment, though, from one of our
Please.
viewers for our panel. I'd like to read it and then let you get to your final thoughts. But Melanie says, I just want to thank all of the ID physicians on this panel and those in the community. It is just awesome to hear the advancements in HIV treatment and prevention. In medical school, I witnessed way too many young men die, and often they died alone. How miraculous to have seen this evolution of medicine. It certainly gives me hope for this COVID pandemic and any virus that we face in the future. Science works.
Wow.
Man, that actually was my close, and she just stole it. Well done, Melanie. That was really
Very
good.
good.
That was
Right.
really
Well
good.
said,
Really.
well said.
Yep.
Yeah.
Thank you.
Dr. Clough, final thoughts?
No, I think there's hope. We have to hang on patiently expectant. We have to look to our neighbors. We have to trust science. We have to get out and get vaccinated, and we have to wait for the information as it comes.
Dr. Shoemaker.
Tomorrow's World AIDS Day, so everybody needs to get tested for HIV.
All right. Dr. Hawk.
I would just echo the comments of my esteemed colleagues and get tested for HIV and get vaccinated if you haven't already.
So
For
here's my
COVID.
story,
COVID.
Jess. A number of years ago, again, I'm old, I had a family member who had HIV and had a heart attack, and people refused to treat him because he had HIV. And his life was shortened by people being refused, even people in the medical profession, to offer care because of fear. As we look and stare down, whether it's the Omicron, and again, folks, it's Omicron, not oh my gosh, it's going to be okay. As we stare down Omicron or we stare down Delta, instead of turning away from each other, we really need to turn to each other. In this, the holiday season, the greatest gift we can give each other is that of faith in each other, hope that we can work together and science that we can trust, which has cured AIDS and can cure HIV. But Jess, it takes every one of us to do that.
Thanks, Dr. Stites. What a great conversation today. A lot of great comments out there. I want to check out, I want to show you some kiddos. We like to end showing our kids getting their vaccine. So this is a picture of Henry, Oliver, and Charlotte. They're from Cincinnati. So they even had special shirts made for this. Thanks, science, and they're vaccinated. So a kind of a big event. I love it when parents and kids make a big deal out of it. Now, this is my kid. This is 5-year-old Dominic this is our family tree. His teacher said this to me, and I said, it's kind of a sign of the times when our family tree and we're all wearing face masks. So I love this. I said, I'm going to put this in our COVID scrapbook. This is the 2021 scrapbook, COVID, the days of COVID. So anyway, well, please send in your pictures of your kids getting their vaccine. You can send those into the Medical News Network at kumc.edu. You can also just email them to me at jlevel@kumc.edu. We'll put these up on the show because we love seeing your kids smiling through their face masks and getting their shots. And thank y'all for just being with us today. We really appreciate it. Tomorrow, we know how tough and expensive it can be to get access to high quality care in those rural areas. The University of Kansas Health System, though, has created a plan that not only makes it possible for you to get those services, but help keep your costs down so your health doesn't have to suffer. So we'll see you tomorrow at 8 a.m. Everyone, have a great Tuesday.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.